Got it. All right, everybody, we're going to go ahead and settle in for our third panel. All right. So my name is Jenna Krickeberg. I'm a psychology student at Pacific University. I'm working towards my PsyD with an emphasis in forensic psychology. And I will be moderating the third and final panel for today, which we are calling Graceful Aging, Managing Degenerative Disease in an Aging Population. So the panel will be the same as the other two panels we've observed today. I will present a question to our panelists who will each speak to the topic for about 2 minutes, and then we can have a discussion afterwards if we'd like. We will encourage the audience to write down any questions they might have for our panelists on the note cards that are probably scattered out around you. We will also have some same members walking along the audience to collect those cards. So just hold them up in the air if you do have a question written down. So without further ado, I will ask our panelists to introduce themselves.
I'm Linda Faust. I'm a licensed acupuncturist, and my private practice is in Beaverton. And I'm a clinic supervisor at OCOM, the Oregon College of Oriental Medicine, and one of my shifts there is at the Hollywood Senior Center, where I have students come in and they treat patients, seniors there at the Senior Center, and I've been doing this for over 10 years. I can't remember, but it's been over 10 years.
I'm Dr. Christie Fleetwood. I've been a registered pharmacist for 30 years this summer and a naturopathic doctor for the last 14 years. I own and operate Monarch Natural Medicine, which is a house call-based membership model. And I'm also adjunct faculty. Okay, so the private practice is up north. I'm in the greater Seattle area, but I'm adjunct faculty both at Bastyr University in Kenmore, Washington, and down here for you guys at National University of Natural Medicine. I'm one of yours. Oh, yeah, that's right.
Hi, I'm Linda Hunt. I am an occupational therapist. I've been an occupational therapist for 35 years, and I teach at Pacific University. I teach in the School of Occupational Therapy, and I also am a professor in the gerontology program there. And I just want to say that I love old people, and I am thrilled to be here today to talk about old people and aging gracefully. So thank you for this opportunity.
My name is Christine Olshove. I'm a chiropractor of 36 years, another wink. And you don't know that you're going into a geriatric practice until 10, 20, 30 years down the road. Your 40, 50, 60-year-olds are now seniors, and you are a geriatric chiropractor. So you do have to learn as you go. My practice is in a home practice now. I've had 4 different models. I've had a big clinic with massage therapists, acupuncturists, and then a second practice of the same but in a smaller building. And then 2 chiropractors. My brother joined me in practice for a short time, and then I went to a home model when I needed to be a mom for one of my nieces. So I liked the home model so well, I stayed home, and I really like it. And I'm also a field lecturer, which is a doctor that goes in every quarter, and I haven't missed a quarter since 1984, which I feel very proud of. And it's in pediatrics, geriatrics, and adjusting. It's been a fun career so far.
Wonderful. Thank you so much for the introductions. So we'll begin with our first question, and Linda Faust will start us off. So the question is, how does age impact the type of treatment or your treatment approach that you're using with your patients or clients?
Well, when we're treating the seniors at the senior center, we have to be careful of not the way you treat with needles and how long you leave the needles in. We have to adjust and not put too many needles in the patient, and not leave the needles in too long, because if we do that, a lot of the elderly, I don't like using the word old people, so I'm going to use elderly people because I'm one of those people and I don't like the word old. Anyway, we have to adjust because a lot of, you get older, your energy drops, so we don't want to tire the people out. So we have to adjust the treatments of, for that reason. We don't want to wipe the people out, but you don't want to get them too tired. So that's one way that we do it when we're treating people with the seniors.
Same with both of my hats. I no longer practice pharmacy, but certainly the older population, just like pediatrics, geriatrics require different dosing strategies because of decreased kidney function, decreased liver function, decreased cardiac function, et cetera. As a naturopath, it's a gentler approach with the older population. So if I'm going to do hydrotherapy, for example, I may use hot and cold towels that aren't quite as hot or quite as cold. It's usually the cold portion that gets toned down just a little bit. If I'm going to choose homeopathy, then I may choose a lower dose rather than, I might go for a 30C instead of a 200C. If I'm dosing with herbs, I might opt for eclectic dosing, which is dosing by drop, more for the energetics rather than a pharmacological effect. And certainly many folks that we see in the geriatric population are on polypharmacy. So making sure that there aren't drug-drug interactions, and when they're on polypharmacy, you can guarantee that they've got drug-drug interactions going on, but also checking for drug-herb interactions and nutrient depletions, huge with the older population.
You try again. Okay. No? Maybe could we pass this first microphone, maybe?
Okay. Testing? Oh, there we go. Okay. So as an occupational therapist, seeing a variety of older adults, we really realize that they have comprehensive needs. And we keep that in mind, that we're not just looking at a disease, a condition with them, but we're looking at the whole person and how that person needs to do their activities to get through the day that bring them pleasure and bring them purpose. And one of the changes that I would really like to see in healthcare is that if a older person is discharged from a skilled nursing facility or from a hospital, from rehab, that there's a home visit performed prior to this discharge, because I think if we don't see that older person in their natural environment, we are clueless as to what they have to deal with. And so as an occupational therapist, we have a skill set to go out and assess community and home safety. And oftentimes that may even include how the person is driving, getting around in the community, accessibility to getting around in the community, and what the safety features are in their home. Many times I've gone into older adults' homes and there's not a light bulb because the light bulb burnt out and there's no one there to replace that light bulb. So, so all these things, the details, we really need to start looking at.
So as a chiropractic physician, time is an essence when we're treating, and because there's younger 90-year-olds and there's younger, slower 60-year-olds, I usually have to pre-schedule the time, and so I lengthen the time for someone who needs it. My chiropractic care format changes from a combination of manual adjusting and deep muscle work, kinesiotaping, electrotherapy, phase 4 exercise rehab, to one of mostly a chiropractic adjusting instrument, which I've learned how to use on every part of the body, from toes to rib cage to skull. And the low force, low speed design of that instrument is perfect for people with osteodegenerative changes in the bone or osteoporotic bone, and it's really been effective. And in fact, the first time I used it was one of my 90-year-old women saying, I want you to use that thing and thump this right here. And I'm game. I've got an open mind. Let's do it. And she felt so much better. We took off on a different tangent. So that's what started a lot of it. Seniors need more muscle work in their neck, but of course I'm going to lighten my force and it's going to be a smoother style of massage and or muscle work. Their drier, thinner skin takes kinesio tape better. It actually lasts longer, but it's more difficult to remove, and I need to get a lighter form. I can't use rock tape on them. I have to use the lighter forms of kinesio tape. And then the last thing is our ice pack high heat rotations changed to a dry heat on low for an hour. And I even had my seniors telling me when I was young, I started at 24 years old, and I wouldn't listen, and they said, but the heating pad works so well. Oh, no, 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 you need ice moist heat. And I know now better, because now I'm 61, and you're right, it does work better.
All right, so our second question for the panel, and this is pretty similar, some things that you've touched on already, but what adaptations have you made to your practice to accommodate the aging population? And this can speak in terms to environmental changes as well.
Oh, yeah, I hadn't thought of environmental changes. So for my practice, I do house calls, so that's the biggest adaptation I've ever done. So I go to the senior's home or the pediatrics home. I do womb-to-tomb care, so anybody's home, that's where I'm going. But the seniors in particular love that, and the new moms. But the seniors, because they don't have to get in the car, they don't have to get dressed necessarily, they don't have to alter their schedule, they don't have to, there's no planning, it's just, oh, Dr. Fleetwood's going to be here at 10:15. But environmentally, I like that because a lot of seniors, working on a fragrance-free campus, I'm not going to be doused with perfume. It doesn't really go with my temperament anyway. But knowing that I'm going to go into someone else's home, I'm kicking my shoes off at the front door. If I know that I'm going to be there for an extended period of time for a particular service that I'm providing, I bring my own slippers because the elder population I have found is so much more interested in me being healthy and comfortable while I'm in their home taking care of them. The younger folks are typically making me tea or making me lunch, but the older folks are like, honey, is it too cold in here? Do I need to? No, I'm good. I brought my slippers. I'm taking care of you, remember? So those are the adaptations, and they're really simple and kind of fun to do.
One topic that I am very passionate about now is frailty. And I really feel it's important for all of us to address frailty prevention with the older people that we're seeing. And there's actually limited research on this as to what can prevent frailty. But what they're finding is that we need to do more to strengthen people's hand strength. So before I started looking at frailty, I was looking at my own aging. I'm 67, and we have these really heavy, industrial pots and pans at home. And I was going, boy, these are starting to feel heavy. I'm going to have to buy a whole new set of lighter cookware to accommodate my aging. And then I decided, no, I'm going to go out and get one of those grippers so I can build the strength in my hands. And that's what I've done, rather than accommodate becoming weaker, I'm stressing that we teach people to become stronger. And we heard a lot about exercise in the last panel and how important it is. And so increasing grip strength, leg strength, getting up from a chair, and also we mentioned protein in the last panel, and you can't build muscle mass unless you consume a certain amount of protein, right? It doesn't have to be from meat necessarily. There's many different sources. And the other aspect of frailty is that I think we need to teach the importance of hydration. Older people don't drink enough water. And I think when you're seeing your clients in the clinic, I really suggest the first thing you do is offer them a glass of water. Please do that. Thank you.
That's a good suggestion. So I'll drink a glass of water. With respect to the physical medicine, I have to talk and react slower. I have to slow down for my seniors. And I have to listen a little more intently. I have to read between the lines and ask a lot more questions. I need to stimulate that memory. Even from my own experience of being where we are, I forget. I can't remember when I hurt my wrist or whatever. I can't remember the day or the circumstances it was in, and I have to write them down. So my office is equipped with large print forms, and glasses are everywhere, all this stuff, the 20 times magnification mirrors in the bathroom. I have my posters. I actually have full-size posters showing active seniors doing ballet, weightlifting, bowling, any of that, because it's all the posters that I used to have were 20-year-olds. Well, I don't relate to that anymore, and I didn't understand it when I was younger. But the cool thing is that my adaptations for the seniors have become for everyone, and that's what's really cool.
So at the senior center, what we've done there in order to adapt to treat the seniors, it's in a group setting. We have some tables that we have set up for the students to work with. We also have some chairs that the patient can sit in. Some of the patients, they're not as comfortable laying on a table, so we put them in a chair. Other people aren't as comfortable in the chair, they want to lay on the table. Sometimes we might have to adjust the type of treatment we're doing. Let's say the patient has back pain, low back pain, we want to put needles in the back. Patient can't lay on their abdomen. So we have to adapt and have them face up, because we've had some patients like this where we have to do other types of treatments, put the needles elsewhere in other places on the body, which you can do. It's called distal treating, instead of putting the points directly in the back. So we've done a lot of adapting there with that, and other things we've done there, we have to make sure the room's warm enough. We have a lot of blankets and pillows to prop the patient correctly. So there's lots of different things you're thinking of at the senior center.
All right, and we have a question from the audience that I think is especially relevant to Doctors Hunt and Fleetwood, who mentioned that they go to and do home visits. So one person in our audience particularly is wondering, how do you manage any safety or legal considerations that might come into working at a client's home?
Well, my capacity into going into individuals' homes was through home care. So I initially was a hospital therapist and then really wanted to embrace community practice, and that was through home care. So, as far as legal situations, I was covered through that process. But if I made changes in a home, such as suggesting that grab bars be put in a shower situation or around a tub, I would always provide names of contractors that I trusted. So I never just said, yeah, you need grab bars right here. I always made sure that I educated people that things needed to be properly installed for safety. So.
I no longer advertise. I am well known enough now that it's word of mouth. So if somebody new contacts me and they want me to come to their home, like I saw the movie Patch Adams, I'm not gonna, no. So they have to tell me who has referred them to me. And if I don't know the person, that's a red flag. And that has only happened once, and the sob story was so good that I went into the person's home and I took care of the gal, but I haven't gotten paid for it. I was there for 2 consecutive days doing constitutional hydrotherapy on a woman with metastatic cancer who already had hospice called in. There was no harm to me, but there has been no payment forthcoming. And whatever. But I don't have any issues with going into people's homes because I know, if not the person who's asking me to come, I know who has referred. I know it's somebody else that I'm taking care of who has given a friend or family member my name. You don't just happen upon my website and ask me to come out. Only that one time.
Would anyone else like to comment on that topic specifically?
I think I do. When I first started my practice, it was my 5th year, and actually one of my patients got me over on a Sunday. And I was held at knife point for 5 hours. So the question is a very valid one. So I don't do home visits anymore unless I know them. And I also felt like I had to look over my back for 5 years. So I don't want anybody to have to suffer that as a practitioner of any kind. So I do the same diligence. I want to see their home. A lot of times I'll go over with my husband first and do a preliminary check, because if I had gone over first to see what the home was like, I would have noticed a pile of clothes on the kitchen table a mile high that his wife had left him, and I didn't know that. You know, I mean, I would have seen some of this stuff. So I feel strongly about being very aware of where you're going. And I often thought about getting a dog, but then I thought, well, I'm going to do this in a different way. But it is a very important question.
And I just want to add that since these referrals were from the hospital to see people in home care, there were times when I would go out with a physical therapist, so we would co-treat at the same time if I thought that I was going in a situation that may not be personally safe for me.
See, this is another great thing about this whole hearing other people and knowing how their minds work, because then it sparks additional information and memory. I actually teach students how to identify your ideal patients. I've been doing this long enough now that I only teach to my ideal students. Like, honestly, I've moved all of my classes off campus. So I just teach to my ideal students, and I teach them how to identify their ideal patients. I only work with people that I adore. And because of the way that my website is written by me, with my values and my voice, like even you being in the audience, some of you are going like, yeah, I got to talk to her. And others of you are saying, goodness, hand the microphone to someone else. Because it's very clear who I want to take care of, because those ideal patients turn me into their ideal doctor, and then we both just have a blast meeting their health goals. So I guess because I am so intentional about who I want to work with, those are the people who 99.8% of the time are reaching out to me. Also, I do have students, so very often I've got a student going with me. I may not be on my own with all of those house calls that I'm doing, because I've got either a new grad who's shadowing me, or I've got a student who's doing some preceptorship hours with me. But every now and then I have the patient who wants to meet me at my house, and my husband has been the one going, no, find a clinic or go to that other person's house. This is my house, I live here, and I don't want any stalkers.
All right, we'll move on to the next question. Thank you for sharing. So the next question is, how do you help your patients or clients to age gracefully? And how do you help foster a positive aging experience for your patients or clients?
There's been some research done on one's acceptance of aging, and it shows that those who embrace aging themselves live an average of 7.5 years longer than people who dread or fear the aging process. And I feel really fortunate because as a child, I was around the most wonderful older adults, and they were role models for me, and I loved, I'm going to use the word old people. I loved old people, and I think that because of that, I wanted to work with older people as a healthcare professional. And now that I'm an older person, I gravitate towards wanting to be around younger people. And so that's one of the reasons I love teaching so much, is because it gives me that opportunity to be around young people. But again, reflecting back on what was said in the prior talk, I believe as an occupational therapist that if we help people engage in purposeful activity, then we are going to help people age gracefully. And one thing that I've discovered is that a lot of healthcare professionals don't inquire if their clients or patients are still working once that older adult is a certain age. And oftentimes older adults want to work. They don't want to stop working. And this is a focus that I think we need to put some attention to, is how we can get older people to stay in the workforce as long as they want to and help them be productive contributors to society through work or through volunteer activities.
Aging gracefully to me is to slow it down. So I want my patients, my ideal would be, is I'd want to slow it down from the inside to the outside. So we look at their food, make sure they're getting enough collagen, the glucosamine. I love bone broth, products, hair products, skin products. What are you using? I like to talk about these. The food supplements that preserve muscles, alanine, and there's a lot of them out there. I want their connective tissue being maintained, so we're going to talk stretching and moving. I want them to rise well, maintain their core strength and daily stretching now, and we start slowly, a little bit at a time. I like to incorporate exercise into their daily routine, like sink exercises for bending, or they're doing dusting and sweeping like the Karate Kid, you know, wax on, wax off. So then we also do benchmarks in my office, which is 6 and 12 inch. I want them to step up on how's the stepping up? Can you step up, can you take 2 stairs at a time? You know, can you do the child pose? Can you even kneel? So I like to go through those, and fall screens are wonderful. At 60, I like to begin challenging my 60-year-old patients. I want you to choose when you are going to make those major decisions. And you get into your head a vision of what is going to be your factor for getting hearing aids. Are you going to wait until the last minute when you've been upset for 10 years that you can't hear anybody and you've isolated yourself? So I want them to actually define what their aging looks like. When are you going to, I asked my own 90-year-old father, when are you going to lose your driver's license? When are you going to stop? And he said, 93. Well, how'd you come to that? Oh, I just think that's when I'm going to be old. Okay, Dad, great. So I want them to determine their conditions and situations and take control of their life at 60. And to me, it's a new beginning. It's not a going down phase into the next phase. It's a new beginning of a different kind of a life. So even, I mean, I've chosen that maybe I'm going to give up my driver's license at 93 too, since my dad feels like that's a good age. And he said he really didn't feel old until he hit 89. And before that, he'd call me and he'd go, gosh, I'm not feeling very well. When was the last time you went to the chiropractor or the acupuncturist, Dad? You know, or the massage therapist? And he said, well, I can't remember. And he'd call me a day, 2 days later. I feel great again. So they forget.
Well, I've been sitting here trying to think of how to answer this question. How do you help somebody age gracefully? And I am going to be 64 in March, and I think about that age and it doesn't feel like I'm 64. Sometimes my body feels like it, but inside I don't feel that age at all. And I remember a long time ago when my mom turned 65, and I'm going to be 65 in another year. And I stop, and the patients we're treating at the senior center, some are my age, some are a little younger, some are in their 80s and 90s. We have a lot of different variety of patients there. When we're sitting there interviewing, the students are doing the interviewing, and a lot of times I've got to know the patients there because I've been there over 10 years. We chit-chat about a lot of different things, and they'll ask me how I'm doing about something. How are you doing? So a lot of it I'm bringing in myself to this work that I'm doing because I'm at the same age as some of they are. So we're talking about things that I'm dealing with too. So how do we age gracefully? I think one of you said, like, you slow down. You're going to slow down. You're not going to do multitasking the way you used to do. A lot of my students are doing more things that I was used to do, and I can't do it anymore, and I don't care to do it that way. I'm still at the paper stage in my charting, and I'm not going to change because I don't want, for one thing, I don't want to. I'm going to be 64. I don't really care to go to health electronics because I could, but I don't want to do it that way because I'm used to this. And I'm going to keep doing what I feel comfortable doing. The part about when you're not going to be driving anymore, I'm like, well, I'm not going to be able to stop. That's how I get around. So thinking about 93 or whatever, it's like, oh, I never really thought about that. So a lot of how I'm helping the students progress with the student or the patients at the senior center, and I have private practice, I have a lot of seniors in my private practice too, is a lot of it I come from my heart when I'm talking with the patients, and I'm really bringing myself into it. Sometimes not every practitioner is like this, but sometimes we'll chit-chat about things that I'm going through too. Not that I'm bringing myself to have the patient take care of me, but they're seeing that I'm human too, and I'm going through similar things at different times. So that's kind of how I've always been with my practice. And I didn't mention early on, I used to be a registered nurse. I worked neonatal when I was a nurse. So I've gone from one extreme to the other extreme in my span of doing the healthcare here.
I think the only thing that I have to add is with my seniors, I want to know what are the major accomplishments that you've had since we last got together. The seniors that I work with are, even though they're in their 80s, they are very involved in their communities. They hold leadership positions in this club, that company, this, whatever. They're doing reading theater, they're singing in quartets or whatnot. They are involved. And I just love to celebrate what they're doing with them because our culture doesn't really seem to embrace age, oldness, and we lose an amazing amount of wisdom when we aren't looking to the older generations to tell us what they know. So I love to know what my older folks are doing and what we can just celebrate and do the little victory dance in the living room about.
I think there really needs to be a lot more in healthcare education about wellness and aging. Oftentimes I explore curriculum from other programs, and there's just like a couple of lectures about aging rather than a whole course on aging. And so I think that needs to change, and I think that will change some of the stereotypes that people have of aging. As I mentioned, I grew up with old people, and I wanted to be an old person when I was 5 years old. I mean, that was being an old person. Oh my God, they were wise, as you said, and they were kind, and they were interesting, much better than my contemporaries, right? So I wanted to hang out with them. And I think we do need to break down these myths regarding aging, and I'm going to mention my daughter because she's here in the audience, but you know, she saw her grandmother in her 90s still being very, very active, and Erin would always say, yeah, Grandma's still kicking it. And you know, it's wonderful for older people and younger people to hang out together. And I think we need to have more of these intergenerational programs, you know, bringing young people to the senior centers to interact with the older adults so that they have these relationships, since many people now don't live where their grandparents are. So I think the more we can get young people and old people together, we can break down these myths and be more enthusiastic for getting old ourselves and for working with older people.
Okay, and I'm going to combine our next prepared question with some questions that have come up in the audience. So the question is, do you think that you are helping to change the stigmatization that comes along with aging? And if so, how? But a few audience members are also curious if you're seeing ageism in your practice as a hindrance in achieving successful treatment or intervention. And another audience member also mentioned that many visitors to China have noticed that the older people there are doing these health-related exercises as part of their daily routine. And how do you think we can incorporate that into our practice in America?
Changing the stigmatization of aging is, I want to be the best example of a 61-year-old chiropractor that I could be. And that's one way. Turning 60 was the beginning of this new upward life for me as far as I was concerned. I feel like I'm more confident. I'm ready to try new things. So then that stereotypical picture of aging that we've been talking about that's depicted in media is started to fade actually a little bit when our current actresses are eschewing surgery. They're saying, no, I want to age gracefully. When Helen Mirren walked out with pink hair, that was a turning point. And so I got blue hair. Change your cut. Change the color of your hair. Do something. Wear a tattoo sleeve. Change it up. You know, do something. Aging can be whatever you want it to be. And that's where I'd like to see the next 10, 20 years go, is that there is no stereotype of age, is that we can, I've got a friend who's 70 and she wears leggings and this little skirt that hangs down and these tops and just all these young people clothes is what she calls them. And she just rocks it. She absolutely rocks it. And I love that. That aging can be what you want it to be.
Just very briefly, my mother once went to the doctor when she was in her 80s and she had certain complaints, and the doctor said to her, well, what do you expect, Bess? You're 80 years old. And my mother looked at him and said, I expect you to cure me. And if you can't cure me, I'm going to go to another doctor. So, so I think that's an attitude that we need to help older people have.
So I asked my kids if I'm dressed age inappropriately because I'm not in my 70s, but I got on the short skirt and I'm rocking it. Thank you. My younger son was telling me that at the ski slopes near where we are, once you hit 70, you only have to pay $20 and you can ski all day. Mom, aren't you excited about that? And I'm like, okay, is this when your older brother got so excited when I was 48 and I have a late in the year birthday? Mom, next year you're going to be 50. I'm like, I'm 48. Yeah, I'm going to be 49 this year, and then yes, next year I'll be 50. Yeah, but you're going to be 50. So I'm asking I'm not even close to pushing 70. I'm in my 50s. I'm the young one here. And quite frankly, damn, we look good. But I thought he was trying to give me grief, and he's like, Mom, no, seriously, I can totally see you on the ski slopes when you're 70. I'm like, right, I'll just strap the skis to my back and ride the motorcycle on up here. Yeah, I am that cool. So I think all of us are active, we're active, and we're actively engaged in our lives, and we're living. So that is modeling healthy behavior for our patients at any age. Another part of the question, though, was, do you see ageism in practice? Yep. Yeah. I've seen ageism actually against me because, well, and I've seen gender disparities out here. I'm not from this side of the country. I'm from the East Coast, from Virginia. Yeah. There's all kinds of stuff that I've experienced out here that I've never experienced in my life before, but yeah, it's a thing. But I love the question about other cultures and how older people are accepted differently and they live their lives differently in other cultures. And couldn't we do that here? Yes, absolutely we can, but we have to be willing to push the paradigm.
Well, I kind of agree with everything everybody's over here has said. I hope that I'm showing my patients that I'm going to be 64, that I'm working and I don't have any intention of stopping working, partly because I can't afford to, but even so, I'm not planning on stopping. I may cut back at some point as I get older, but I see myself always doing something with acupuncture. It's not that difficult to do, but I don't see myself not working because I would get totally bored if I didn't work. And I'd eventually find out, what am I doing? I can't just sit at home, do nothing. You'd also mentioned about in China. I forget what the question, what you said about.
Yeah, someone had mentioned that visitors to China noticed that the older population there have already incorporated health-related exercises as a daily
Exercises.
routine.
I know that at the senior center they do have. Now I don't teach it there, but they have in the afternoons. They have someone coming and teaching Tai Chi there. I know another day they have a yoga class there. So there's lots of different activities at the senior center where I have acupuncture, that they have other activities. There's other exercise classes, but they do have Tai Chi, they do have yoga, and a lot of the people do participate in that there. So it is going on.
Wonderful. Thank you. Okay. Next question for the panel. What is or what are some of the most common age-related complaints that you encounter in your work, and how does your specific profession treat these symptoms?
Well, we treat a lot of different complaints at the senior center with acupuncture. A lot of the common ones, low back pain, knee pain are common, all different kinds of pain, but a lot of knee pain, arthritis. Acupuncture works really well with all these conditions. Some people come in with like peripheral neuropathy if they have diabetes or not diabetes. So with a lot of those we can treat. A few people are coming in with, they don't always talk about it a lot, but a few people with emotional things. One of the patients has grief, her husband passed away, so we're dealing with that too. And it's nice because we have, the way it's set up there, it's a group setting. A lot of the patients get to know each other before they even come up for acupuncture. They sit down at, when they're waiting for us, they sit down at these tables and they get to know each other pretty good beforehand. So a lot of them are chit-chatting about their issues before they even come up to talk to us. So there's a lot of that going on where they get the community type thing. It's not just one-on-one, but it's a community type thing.
So I don't specialize in gerontology. So I was trying to think, what are the specific things that are happening in the older population? And certainly there's osteoarthritis, there's the rheumatism. There are also concerns with cognitive functioning. And then there the gals who are post-menopausal and afraid that everything in life is going to now perish because they have passed into post-menopausal arena. So if I were to look at each of those things, would be here all day. But a lot of it is just, it's removing the obstacles to the patient's cure. And whether that is sitting with the elderly man whose wife has just been moved into memory care because she has severe Alzheimer's, and honestly he hires me to come in on a routine basis so that he has a reasonable adult conversation. Or if it's the newly menopausal gal who thinks that life is now at an end because she no longer cycles, and she's wondering what bioidentical hormone replacement therapy I could put her on, you know, then it's a matter of saying, really? You came into this world with very, very little in the way of hormones, and it wasn't until puberty when everything started going like wild and crazy, and then you normaled out. Really, do you think you're supposed to go out of this world with your hormones way high? No, that's what perimenopause is about. It's like the reverse of puberty, and then you're not supposed to have a whole bunch of hormones. and that's normal, and that's okay. And culturally, the U.S. women suffer more with menopause than other cultures. Why is that? Is it Disney? Maybe. Is it our media and the worshiping of skinny, white, blonde, young women that are airbrushed? Maybe. So having conversations to just sort of normalize what the process is. We don't have to be medicalized when we stop cycling. If it's a brain issue, like I can't think, dementia runs in the family and we got to do something because I can't remember anything. Again, kind of demystifying and normalizing what they're experiencing and getting them to recognize that if they tell themselves constantly that they cannot remember, then that enforces the fact that they cannot remember. What if you told yourself, I got this? What if you began to memorize things on a routine basis? Maybe you take a really, really short favorite poem or just a stanza, a song that you love, learn the lyrics and sing it to yourself. You know, just coming up with common sense ways of approaching whatever their fears happen to be.
I developed a list of questions that I thought you might want to ask your patients and clients. So let me give you this list, okay? So first on the list, you might want to ask them, how often have you, the patient, felt full of energy? Okay? And you could see that participation in activity is really the bottom line for these questions. We need to be asking our patients, when they go up the stairs, are they now holding on to the rail when they never used to before? And is that a sign of their legs becoming weak? Is it a sign of low endurance? Let's ask that question. We want to ask a question about whether they get out of breath when they walk around the grocery store. You know, many older adults now don't like to go to the grocery store because it wears them out. So let's ask questions about that. And we need to pay more attention to age-friendly businesses, educate businesses on the needs of older adults so they can go grocery shopping. Is the person becoming more sedentary? So are they sitting more than doing anything else throughout their day? And when they do go to the grocery store, do they come home and put the cold items in the refrigerator or freezer and then leave the cans and boxes for some other time because they're too tired to deal with it? And I mentioned those heavy pots and pans. So I think we need to ask them, you know, do they have a loss of appetite? And we talked about nutrition in the last panel discussion. And one thing that wasn't mentioned, but as an occupational therapist, if somebody has a stroke or they have an injury and they have some disability because of that, we can help find ways for people to engage in being independent in cooking. Using one hand to, you know, make a complete meal, those sorts of things. So it's not just the nutritionist that needs to be called in, but it's the occupational therapist as well to help people prepare those nutritional meals. Thank you.
So one of the most common age-related disorders I run into in physical medicine is knees. And Americans do not sit, stand, or walk right. The Asians do. And so I like to teach my patients how to do it properly, and that helps with the knees. But the biggest symptom that I get is the popping, clicking, sharp pain like you're going to drop for no reason, and then it's just gone, and you're just finish your trip of wherever you're going. It disappears in a flash. And the swelling that happens in the knees, that no medication helps. That's one of the most common symptoms. And the diagnosis is a combination of tibial malposition, plica, and bursitis. And what helps it, it's actually cured. It can be cured and controlled by kinesiotape. So I teach them how to kinesiotape themselves because it's going to take 6 weeks of kinesiotape on a regular basis. Daily dry heat on low for an hour, and then daily stretching of the lower hamstrings. And that's one of the things that where Americans fall flat is we've been told that that stretch where you touch to your knees stretches your hamstrings, and it doesn't stretch the lower hamstring. You have to actually grab the lower hamstring and pull it and stretch it or squat. And that's what Americans don't do. We don't squat, all right? So that is one of the most beneficial things that I teach for my patients, and it really keeps them moving and rising better, is loosen up your hamstrings, loosen up those lower hamstring tendons, and then start dry heating those joints that hurt. The second most common thing is the memory, and one of my passions is cooking. And I don't like American ovens because they're not automatic. They don't automatically go off. What I like are those convection tabletops. So we trained my father, who I mentioned was 90, and he now has a convection oven on top of the stove. If it goes off and he's out there working in his yard or chasing his cat or whatever he's doing and it goes off, he doesn't have to worry about burning down his trailer or his house, right? And so then that's one thing I like. I'm not wild about microwaves because they give off radiation. There's a lot of pacemakers out there, and I don't think that the food is good out of a microwave, but heating up something occasionally is not terrible. But that is the one thing that I like. And then the other thing is steamers, like the automatic cookers that turn off. So we don't have to worry about memories. Somebody can stay in their home longer. So I have a whole bunch of recipes and everything for my seniors and involve these 2 appliances. And I'd like them to change over from one to the other. And that way they can prepare themselves and get their memories in their 50s for how to cook food, natural and organic and real food. Because like when I went home to visit my dad, this was his menu. I have a half of a muffin in the morning that's out of a box in plastic. And then he had a pot pie for lunch. And then he had the other half of the muffin. And then he had, for dinner, was another boxed food, and he had half of that. And I was appalled. I mean, I'm a 36-year chiropractor. Oh my God, Dad, what are you doing? So we got him into these 2 appliances, and he's eating fresh food, and I'm so much happier about it. So it's become a passion a little bit of mine.
All right, we're just about wrapping up with the panel today, but if you wanted to, in 20 or 30 seconds, just share with us what has been the most surprising or unexpected thing that you've discovered or learned about aging. Any insights for us?
I got one. I am surprised at how fast an ability can disappear. Okay? When I was 40, I couldn't do a cartwheel anymore, and I've never gotten it back. I can't squat at 60. I'm just now trying to get it back. And when I was 45, all of a sudden I couldn't step up on my chiropractic table to pin something to the ceiling because I have little pictures for the children on the ceiling. And it's just how fast something can disappear. So if you make up your own hallmarks. Like I want to be able to do this until I'm 90. You've all seen that picture of the ballet woman that's 70 or 80 or 90 years old. She's got her leg up the fine signpost all the way up. I want to be that. You know, I want to be that gal. So that's the biggest one for me. Wow, it goes fast.
I want to draw your attention to, there was an article in the New York Times. It's called, "Want to be happy? Think like an old person." And it talks about how older people found peace, joy, and less anxiety as they age. And it's from a book that's coming out on Tuesday. And the book is called Happiness is a Choice You Make. Lessons from a Year Among the Oldest Old, and it's written by John Leland. So John Leland, let's go get that book. Okay.
I think my biggest shocker is the opposite of Chris's. I'm in my mid-50s, and I'm healthier now than I was when I was in my mid-20s, which is alarming on one hand, and fantastic on the other hand. The 30s were better than the 20s. My 40s were better than my 30s. My 50s are looking stellar. So I'm thinking by the time I'm 90, life's gonna be golden.
I think for me, the biggest thing that I'm looking at for myself is, I know I've slowed down a lot, but the biggest thing for me, I think, is, this happened at Thanksgiving. I can't eat some foods that I used to eat, that used to be able to eat, like apple pie. I can't even eat that anymore. So it's like I have to really watch what goes into my mouth. So it's like I'm eating healthier now than I've ever had in my whole life. The other thing that it's going is my eyes. It's like all of a sudden, I've got readers up here, but I'm going to have to get real prescription glasses that I just found out. And it's like, oh no, my eyes, what's happening? And it's like, I don't want to lose my eyesight. So that's happened, kind of what you're saying over there. It's like, oh, my eyes are getting old. What happened overnight? It's like, I think they've been slowly going, but I just have been adjusting. You just adjust and you don't pay attention. You're just like, I'm seeing fine. Then all of a sudden I had to go to the eye doctor and it's like, oh, I'm not seeing as well as I thought I was. I even flunked the top line on the eye exam chart. I'm like, oh my goodness sakes. So you adjust. A lot of things you would just adjust, but I'm kind of surprised at some of the things I'm seeing.
Well, thank you so much to our panelists. Let's give them a round of applause. And we're gonna take about a 5 to 10 minute break before our keynote, so please join us out in the atrium, grab some snacks, refreshments, check out the raffle, register if you have not, and make sure you sign out for the CE credits for this panel.